Good morning, honorable members of the Pharmaceutical Society of Kenya. Our guests from other cadres, our distinguished speaker for this morning, our moderators, ladies and gentlemen, my name is Daniela Munene. I'm the CEO of the Pharmaceutical Society of Kenya, and I'm very honored to be your host this morning for this edition of our Pharmacy COVID-19 Dialogues. This is a webinar we have every Wednesday at 11 a.m. where we share experiences amongst ourselves about how we are combating this pandemic. And today we have a very exciting presentation lined up for you. Let me introduce you to the moderators who will take us through the program today. Our first moderator is Dr. Michael Mungoma. He's well known to almost all of us. He's a member of PSK. He's the Dean at the School of Pharmacy at MKU, which is Mount Kenya University. He's a member of the PSK National Executive Committee of our National Governing Council, and he's a member of the PSK COVID-19 Response Task Force that organizes these webinars for you. Karibu sana, Dr. Michael Mungoma. Please say hello so that we know you're there.
Good morning, everyone. I'm happy to be here.
Thank you. Our next moderator is also very well known to almost all of us, Dr. Sylvia Opanga. She's a member of PSK. She's a senior lecturer at the School of Pharmacy, University of Nairobi. She's also the chair of the Education and Public Health Committee of the PSK COVID-19 Response Task Force. Karibu sana, Dr. Opanga. Please say hello to the participants.
Good morning, participants. I can see we are almost 150, so you're so welcome.
Asante. It's good that people have joined early. So I will hand over the program to Dr. Mungoma and Dr. Opanga. Asante sana.
Thank you very much, Dr. Daniela, for the nice introduction. So let's quickly go to the program of the day. We have a few ground rules. Please, next slide. Yes, we have a few ground rules and announcements before we start the webinar. So participants are muted during the entire course of the webinar. Please ask questions via the Q&A tab at the bottom of your window. Do not field your questions through the chat. Questions shall be addressed by panelists later in the program, and that's usually after the speaker has finished talking. For PSK members, if not already done so, please subscribe on the PPB portal for today's webinar so that you can get your CPD points. For KPA members, the attendance list will be forwarded to the officials for awarding of your CPD points. Please note, for PSK members, CPD points will only be awarded to paid up members. This webinar is being recorded and the audio will be made available on PSK's YouTube page. So for the program of the day, today we only have one speaker, and I believe she has a lot to tell us. So once we are done, I'll just hand over to her. She'll be talking about infection prevention and control in the era of COVID-19. After she has finished, then at 12 noon, we'll take any questions, and then that will be the end. So I'd like to introduce Dr. Wesangula. I know a lot of you know who she is, but she is a pharmacist with extensive experience in the health sector, where she has mainly focused on policy work in the area of antimicrobial resistance. She has been a consultant in the AMR Secretariat at the WHO, Geneva, where she supported development and implementation of the national action plans on antimicrobial resistance. She has also held a role as the national focal point for AMR at the Ministry of Health Kenya, where she was key in establishing and coordinating the national AMR program as well as developing the national AMR policy and the AMR National Action Plan, including antimicrobial surveillance. Her current role is the head of the Patient and Health Worker Safety Division at the Ministry of Health Kenya, where she builds partnerships for patient safety. Dr. Wesangula holds a BPharm degree from Dr. MDR Medical University in Chennai, India, and an MSc in Tropical and Infectious Diseases from the University of Nairobi. She's an active member of the Pharmaceutical Society of Kenya. She's also a very good friend of mine. So, Dr. Wesangula, karibu sana, and over to you.
Thank you very much, Dr. and good morning to all the colleagues that are on the webinar this morning. And like you've heard, I work with the Ministry of Health, the Division of Patient and Health Worker Safety. And this is the division that actually is responsible for infection prevention and control at a national level, and also antimicrobial resistance and broader patient safety work within the country. So I want to really appreciate the opportunity that has been given to me this morning to talk about what it means to implement infection prevention and control guidelines during this COVID-19 pandemic. So I'm glad that I'll be able to maybe share a little bit of what we are doing and what is happening around the country. I know it's a broad area of focus and we might not be able to delve into everything, but I'll just try and go through the highlights on infection prevention and control and what that means at different levels. So thank you very much, and I'm looking forward to interactions at the end of this session. So of course, we are all here because of what's happening in the country, and as at the 4th of August, which is just yesterday, we had 23,202 confirmed cases. And we know that we are now at community transmission, extensive community transmission of COVID-19. And apart from that, now all the 47 counties have reported a case. Remember, at the beginning of the pandemic, we had one county, we moved to 2. Last week, we were at 46 or 45. And now all the 47 counties have reported a case. So what that means is that the level of alertness needs to go higher. And if it's interventions that need to be put in place, I think we need to strengthen that as well. And one of the areas that probably needs to also have a bigger focus on is the community level. And from the pharmacy perspective, a lot of us are attending to patients or clients at the community level. So what does that mean for us, even in terms of infection prevention and control? I know a lot of focus has been on healthcare facilities or hospitals in particular, and we forget we have other practices that are so embedded in the community that equally need to be on the same discussion table, implementing the same guidelines that are developed at the national level. So the other point that I also just want to bring up is that the healthcare workers' exposure to COVID is on the rise. We have more than 600 exposures that have been reported. So for us, that's a concern, and it points to many things with widespread community transmission. The possibility of healthcare associated transmission also increases at the end of the day. So if you look at our cumulative case loads, you can see, of course, we are on the rise. The trend is on the upward move, and we haven't managed to flatten our curve as we had intended. We hoped to flatten the curve so that we don't have an overwhelmed system at the end of the day. And you can see the number of deaths, of course. We are heading towards the 400 mark. And that means we have many more recoveries that are happening within the population. So of course, as we work towards the process, we know that one of the critical components for us would be to preserve a health system that is functioning. That is what is critical. And as we interact over the last week, the distress, I think, signals that are going around is that the healthcare system is overwhelmed. There are no beds in hospitals. So then that prompts us to begin to think about the place of prevention. If that can happen, then the system is spared the place of being overwhelmed. We've already begun implementing home-based care. Of course, we think about the outpatient setup, you're thinking about emergency rooms, you're thinking about hospitalization, and all these are concerns for us as healthcare workers and of course the general population. So the other point that we need to also prepare for is the point at which facilities may need to respond to a surge in patients that require care. So what measures have been put in place, for example? So what that means for us is that we need to have concerted efforts so that we can mobilize all aspects of our healthcare system to reduce the transmission of disease, and at the same time also be able to direct people to the right levels of care and decrease the burden on the healthcare system. So of course, all counties, like you all know, at a country level were called upon to heighten their level of preparedness to respond to COVID-19. And I'll just be going through some of the findings from the assessments that have been carried out to show us where we are at. So in terms of the situation, we looked at IPC. We had the Health Emergency Response Project that went out to assess the level of preparedness. So for infection control, I think when you have findings like this coming back, showing that less than a quarter of all our facilities are equipped with all items for IPC, I think that's a point of concern, because then that means we cannot be able to effectively prevent the transmission of infections. Looking at the levels of care, the second that are managed by the private sector actually recorded the highest number of facilities with all the required IPC items. So that also is a pointer to the level of preparedness in our public facilities. My last bullet, I think, is a concern. With widespread community transmission, the dispensaries, which probably pose like the first point of care, had the least availability of items that are required for IPC. And you can see it's just above 1 in every 10 dispensaries reported to have all items. So those are points of concern if you're talking about IPC. And you're looking at basic things like water, you're looking at availability of soap or hand sanitizers, and if these are missing, then it's a challenge. So you can see from this graph, you're looking at the average score. In terms of readiness for all items, only 23%, and we had about 1,400 healthcare facilities that were assessed. In terms of availability, and you can see the place of training, having at least half of all the frontline healthcare workers trained on infection control. If you have less than half of this trained, then it's a challenge. All of us need to have proper information on infection prevention and control for us to be able to adequately implement the guidelines. This is another point of concern, outpatient departments, and a lot of the exposures to healthcare workers have actually happened in the outpatient department. And you can see in terms of availability of necessary IPC supplies, the least available was hand sanitizers and to some extent soap. And we know that hand hygiene actually is one of those interventions that can reduce the transmission of healthcare associated infections by up to 80%. So in the absence of effective hand hygiene, the possibility of transmitting infections is even higher as we attend to patients. This is the other area of concern, like in the intensive care units, and you can see the levels of preparedness, IPC supplies in ICUs for those that had all items. Those are the orange bars. You can see like the private NGO or primary hospitals, only 27% of the ICUs had about all items in stock. For our public facility, you're talking about 70, and the national average came to about 39.9%. And the unfortunate bit about scoring for IPC, IPC is an all or none. you never have an in-between. So if you don't have soap, that means hand hygiene is not happening. If you don't have adequate PPEs, like if you don't have an N95 mask, you cannot say that you have actually stopped the transmission of infections, because all these are all interrelated. Again, comparing the availability of these IPC supplies, like in the inpatient department, the outpatient ICU and isolation wards, you can see ICU is still doing badly. And this is an area where you have critical patients. The risk of HAIs is even higher. The possibility of poor clinical outcomes, again, is further worsened in the absence of proper infection prevention and control measures, because the patients in ICU already are at immunocompromised state. So it is so important to have the proper infection prevention and control measures in place. We also look at the isolation ward. We expect the isolation ward to be at 100%. We shouldn't lack any IPC supplies in the isolation facilities. But if you have an average score that is less than 50, then what that means is that exposures and to healthcare workers is high. Of course, that makes it a high-risk environment. Critical supplies we looked at over the last 2 weeks: the availability of eye protection and N95 masks. First, the N95 mask, you can see 64% of facilities didn't have supplies to last 2 weeks. So in the event of a surge, the facility would not be prepared. And again, not just the N95 masks, but also basic things like eye protection were missing. This was an interesting observation. You can have all the supplies in place, but we have realized the place of compliance is also a challenge. And I will keep making reference to hand hygiene because it is a critical component of breaking the chain of transmission in infection prevention and control. And you can see out of the 810 observations made, actually this is an assessment that is currently ongoing. So as of yesterday, we had about 810 observations that had been recorded. And there are 5 moments when hand hygiene needs to be practiced. And before touching a patient, about 38.7% of the health workers who were observed actually practiced hand hygiene. After contact with body fluids, you can see the percentage that actually practiced hand hygiene was even lower. After coming into contact with the patient's environment, again, this is one of the most forgotten moments for hand hygiene, when we leave the patient environment and nobody performs hand hygiene, and you move from one area, you either go to the nursing station, or you go to the common room within a facility, or you go to where the records are being kept, then you realize that's a big challenge as well. So if we do not comply to hand hygiene, then we cannot be able to effectively break the chain of transmission. So of course, I also want to focus on health worker safety. We know when as health workers, we are at risk, then everybody else is at risk. We 28 healthcare workers who've been infected with COVID. And this was data that was available to us up to mid-July. That's the 19th of July. And I just want to share with you a bit of this data so that when we begin to look at the different components of infection prevention and control, we are able to see what are the possible points of mitigating the transmission of infections. So we got this data from the Emergency Operations Center, and we had interviewers who actually conducted the interviews with the health workers. And it was a difficult, this was a difficult activity because of the stress levels for healthcare workers that have been infected while on duty. And we wanted to document the incidence of exposures and infections. We also wanted to establish the risk factors. We also wanted to establish the priority cadres so that we can intervene appropriately. And also understand the impact of current interventions and gaps, because we can develop so many guidelines and we can buy a lot of supplies, but if we don't understand the impact of the current interventions, then it becomes a challenge. So you can see we had 355 cases recorded as of 8th of July, and we had contact information available for around 288 healthcare workers. Not all of them responded. Some opted out. We also realized some of them were not healthcare workers. They were contacts of healthcare workers. Others didn't pick calls. Some rescheduled calls. And others say they were actually not positive, but negative. So we had those that were interviewed. And you can see their distribution by county. Nairobi had the largest number of healthcare workers exposed. And you can see quite a number of counties there that reported cases of healthcare workers exposed and had turned, of course, turned positive. By facility, and that's why when it comes to the implementation of infection prevention and control, it has to be across board. There are no guidelines for public sector or private sector. Guidelines are just guidelines. And you can see in terms of distribution, the private and public sector took a big a percentage of those that had been exposed. We also had exposures at the community level, and of course, some FBOs also. In terms of the cadres, you can see the top cadres, 66% of these were nurses, clinical officers, doctors, and lab personnel. We've come across pharmacists that have been exposed while they are also providing services. And I remember walking into one facility a week ago, and as the pharmacist was serving the clients at the window, and these are clients who are coming to take medicine at the facility. That means they have to lower their masks, have the medicine administered, and in the meantime, there's a conversation that's happening between the pharmacist and the client, and the pharmacist only has a face mask, but no face shield. So as they converse with the client, the possibility of transmitting infections are high. And that's why every time we attend to a client, it's important to carry out a risk assessment so that you can have the appropriate personal protective equipment with you to be able to protect us appropriately. So that was the distribution of those that were exposed. And of course, the last, the green box, you can see we also have support staff. Many times we provide capacity building for those that we call frontline healthcare workers, the ones who've gone to a medical school. And we forget the same support staff who goes in to clean an isolation unit, or the same support staff who cleans your services is also a health worker because they're providing a service in the healthcare environment. We also had support staff that were infected. And this also points to the level of support we give them. Do we provide appropriate PPE for them as well? The kind of a surgical mask that you will use in the clinical area is the same that should be provided to the support staff who's working with you in the same environment. So it's important that this particular category of staff are also considered. We also looked at the facilities where these staff work. And in many of their facilities, they said, yes, there's an IPC committee. Some of them said they didn't know. Infection prevention and control is basic. Anyone who's working in a facility needs to be aware of what mechanisms or what committees do exist in the facility for purposes of better communication and also receiving better support. Some had some level of general IPC training in 1 year, and I will say this because I've been working in this space for more than 6 years now. And before COVID, no one talked about IPC. We could shout and we could talk about guidelines. Nobody wanted to look that direction because everyone thinks that IPC is an expensive affair. You invest so much and you don't see the returns. But the returns come in the form of improved quality of care. And in the long time, when you reduce the hospital stays, there's a net profit in terms of the savings that a healthcare facility can be able to realize. So there's been very little investment in the area of infection prevention and control at a country level, even before COVID. But now, of course, with this, we don't have much of a choice but to invest in infection prevention and control interventions. Those that had COVID-specific training, about 50%. So what this points us to is that, yes, we have a gap in terms of reaching all healthcare workers. At this point, all of us should have had some form of COVID-19 training. How many had been trained on appropriate PPE use? You can see again a similar distribution. almost half-half, and we normally say if you do not have the appropriate information on how to use any piece of the PPEs, then it will not serve the purpose, because then it stops being effective. Like a good example is the general use of masks in the society. And you can see people are struggling with even just using a mask in public. It's either worn under the chin or it hangs around the ears. So you can see if we are struggling with the use of masks, then the protective or the level of effectiveness also diminishes, depending on how well we are able to use this. Same to training, there's still a big training gap when it comes to COVID-19. We also looked at knowledge and compliance, and I will keep referencing hand hygiene. We wanted to check whether healthcare workers were aware of the 5 moments of hand hygiene. 80% said yes when we asked, are you aware? But when we checked, we followed up with a question, further probing. Actually, only 32% knew and understood the 5 moments of hand hygiene. That's before touching a patient, before an aseptic procedure, after coming into contact with body fluids, after coming into contact with the patient's environment, and after touching the patient. Those are the 5 moments of hand hygiene. And many of us thought that actually hand hygiene was just before touching the patient and after touching the patient, and then the usual after using the washroom and things like that. So it's the compliance can only be enhanced if the right knowledge is in place. So when it came to PPE use, again, you can see we had breaches. Some used the surgical masks, others used the N95. And when they were conducting some aerosol generating procedures, you can see like 9% didn't use an N95 mask. And we know clearly, then that makes the exposure a high risk exposure. So we also asked whether risk assessment is done, because with continuous exposure, because of the extended community transmission, it's important for risk assessments to be conducted for all healthcare workers in the facility on a frequent basis. And you can see 14% of those that turned positive didn't even know whether or not a risk assessment was done. So that is clearly it wasn't done. And for some of them, the risk assessment was conducted, and the risk assessment scores indicated that it was a low risk, but they still ended up positive, which is you begin to query the kind of risk assessment that was conducted. So you can see like 50% didn't have a risk assessment done, and they didn't even know whether or not risk assessment needs to be done. So we have an infection prevention and control risk assessment tool that is part of the national guidelines for infection prevention and control for COVID. So this allows the person who's in charge of infection control to run a quick check on the levels of exposure of the healthcare workers within their area of work on a regular basis. The risk assessment tool is able to address whether or not the healthcare worker was in close proximity with a patient maybe that was positive, because we've had cases of COVID patients being found in a general ward. So how then do healthcare workers respond to such a situation? Then a risk assessment is conducted on the activities that the healthcare worker did, the type of PPE the healthcare worker had on, and how that PPE was worn, whether hand hygiene was practiced or not. So it assesses quite a bit, and it's an important element for infection control. And we also had the question about working after exposure. And I think the biggest concern here is that sometimes we have healthcare workers that continue to work even after exposure, and as they wait for results to come, and after results come back, they are positive, and yet they were exposed initially to a positive case but continued to work. So what this does is that it actually makes, it provides for continued transmission to other healthcare workers or even the patients. So ideally, after exposure and a risk assessment has been conducted, then if it's a high risk exposure, then the healthcare worker should actually not continue to work in the environment until the results come out. And of course, if there's a place, if it warrants isolation, then the health workers are isolated. So the risk factors for healthcare worker infection that have been actually now kind of that have come up. One is the lack of personal protective equipment. And of course, it's not just about that, but the appropriate use. And that can only be driven by understanding the pathogen and also exposure to infected patients. We also appreciate that there's a place of work overload. For a long time, we've had staff shortages across the whole system. And of course, the place of poor infection prevention and control. When you lack established practices and you don't have protocols, then of course we will not be able to implement the right way. Then the place of inadequate training that has come up, direct contact with contaminated surfaces. So we are moving away from just talking about PPE and training. We are looking at basic things like environmental cleaning. How are our surfaces cleaned? How effective are the cleaning processes? Who monitors the cleaning processes to make sure that the right disinfectant has been used? And not just the right disinfectant, but the appropriate contact time of between the disinfectant and the surface has been observed for effectiveness to actually happen. And of course, how do we also clean linen, for example? And of course, are we taking into consideration healthcare workers with pre-existing medical conditions? So now, of course, after we have seen what the situation looks like, of course, now we begin to realize that IPC is basic, is really a basic requirement. It's one of those things I normally say is non-negotiable. You cannot negotiate with having running water or not in a healthcare facility. And that could even be the pharmacy. That should not be a question that should even arise. So it's such a basic requirement for safety, for quality of care, and a critical element for any outbreak preparedness and also for readiness. And I will keep saying this because we had not invested enough in our systems. We had not invested enough even in infection control. So of course, at this particular point, when you're responding to a crisis, it becomes a struggle because it's a double investment. Investments that should have made into the system earlier are now being made. And then plus what you need to invest into a system when you're responding to a pandemic. So it's actually like a double like budgetary requirement. So of course you have infection control being an ongoing process, and that's what we hope to see even post the pandemic. And it is normally guided by a set of practices. Hand hygiene doesn't change. The 5 moments don't change, whether you're in the UK or you're in Kenya. So it's a set of practices and you have protocols. That's why we develop even guidelines for basic things like cleaning utensils or cleaning linen or cleaning surfaces or even just the use of catheters. It's basic and you have procedures. And this is one of the things we find lacking in many healthcare settings. People know things verbally, but very rarely will you find policies that are displayed or protocols that are displayed for ease of reference at the point of care. So without this, it's very hard for us to have sustained action in terms of quality of care and minimizing the transmission of infection in the process of providing healthcare services. So these are some of the things that can run in an infection control program in a facility. Continuous surveillance of healthcare associated infections. This rarely happens in many of our facilities. So we don't know whether our patients have HAI or they're just sick because of what brought them into the hospital. Without surveillance, it's hard to know. I've talked about the guideline implementation and the local policies. And of course, infection control doesn't exist on its own. There are many other teams that they can collaborate with. We've also found a weak point in occupational health and safety programs in healthcare settings. No one talks about the health and safety of the healthcare workers. The records are not even there, so that if you begin to look at occupational health and safety for purposes of improving services or compensation, you have a very weak system that you can maybe lean on at the end of the day. So this is an important slide in infection prevention and control, and it will help us also begin to focus our efforts and our resources in terms of response to the pandemic and even beyond. When it comes to effectiveness, we have this hierarchy that informs our investment. And I like this because it really brings out the PPE component as being least effective. This doesn't diminish the importance or the place of PPEs, but it makes it one of the least effective controls for infection control, because the use of PPE is highly, the effectiveness of PPEs is highly user dependent. I can have the best N95 mask, but if my process of wearing it and removing it, or the donning and doffing of my N95 mask is amiss, then it becomes ineffective, because I can get the infection just at the process of removing the PPE. And we realize a lot of people get infected at the point of removing the PPE. It could either be a substandard one, or the use is compromised because the user does not have the requisite knowledge on how to use it or even when to use it. And the user also probably doesn't have knowledge on how to assess risk for selection of PPEs to use at which point. And the risk assessment simply tells us, first of all, I want to evaluate what part of my body will be exposed. If it is a procedure that will require contact, then I need gloves. That's the way you carry out a risk assessment. If there's a possibility of splashes, then I would require a face shield or the goggles. If the pathogen I'm dealing with is a respiratory pathogen, then definitely I will go for a mask. If I'm going to come into contact with a lot of body fluids, then I would need extra covering on top of my scrubs if I'm using it. So it comes at the bottom of this pyramid, because the effectiveness largely depends on the knowledge that the user has, so that they are able to use the PPEs appropriately for their own protection and even for the protection of those that are around them. The second level is administrative controls. These are really useful and effective, and administrative controls cover things like policies. Do we have policies that are practical in our workplaces? Do we have procedures and protocols that are clearly displayed and clearly and actually known by all the staff that are in a particular facility or area of work? Are there clear changes in terms of work practice? Are we flexible enough to change the way people work? Like we say, when you carry out your risk assessment and you find that half of the people who used to work in ICU are 58 years and above, do we require to make a change when it comes to how this is being implemented? So you can change work practice by changing the way people work, but this has to be effected through policies and procedures that are shared or disseminated with everyone, and it enables the place of implementation. The next effective level of infection prevention is engineering controls, and this requires physical changes at the workplace, and that's why we keep hearing we've been asked to put up 300 isolation isolation facilities with 300 beds. But when you go to the actual work, you realize it's not just about beds, the infrastructure, the design, the flow of patients, the flow of staff, the flow of equipment, the flow of basic things like linen and food within a healthcare setup. All this is actually affected by infrastructural designs. You can have a hall and have beds in it, but does it have the plumbing works in place? Does it have the right taps, for example? Does it have the right flow material or the ceiling? So all these engineering controls, if these are in place, can provide an opportunity to isolate people from the hazard. And I like giving a simple example. In many of our hospitals, when we ask, do you have an isolation ward for your TB patients? And they say, we really don't have an isolation ward for TB patients, but we keep them at the end of the ward. That doesn't isolate people from the hazard. It's just a psychological, I can say it's like therapy, because I know that patient is at the end of the ward, but it needs to be physical isolation that requires a change in the way the workplace is structured, the way our inpatients are structured, the way work is flowing, even in the outpatient. And at this particular point, I just want to mention the triage area. And when many hospitals realized they cannot build a new outpatient department, hospitals have put up tents as temporary triage areas, as temporary consultation points, so that you're able to work on the engineering controls and make the physical changes that you can be able to afford. And finally, of course, the most effective would be to eliminate the hazard. If we could remove it, that would be the best thing. If we had a cure for this, it would also be the best thing. So those are that's the hierarchy of controls for infection control. So anytime you want to invest in infection control interventions, think about these 4 components: the PPE, the administrative controls, the engineering controls, and the elimination. Then we have the components that will drive these processes. And that's why we say you just can't focus on one area. You have the guidelines, you have provided education and training opportunities like we're doing now. You have constant surveillance to understand what's happening around the environment. And we must continue to monitor, audit, and give the feedback. Like now, once we have feedback on hand hygiene adherence, we are able to go back and say to the counties or to the facilities, this is where you are at. And of course, if you have an enabling environment that is improved by workload reduction, you have the requisite staffing, and that's why we've been talking about hiring surge staff for this particular period. You're talking about bed occupancy, and of course your environment, like we have talked about. These are just some of the guidelines that we have. We are currently finalizing the review of the National Strategic Plan and the General IPC policy, and I'm sure in the next 1 month this will be out. Of course, the priorities, the place of management, leadership, and governance. If the management and leadership doesn't understand what infection prevention and control is, forget the rest of the 6 priorities, because they require some level of investment. And until the management understands that, then they can be able to allocate resources and they can be able to support the functioning of the teams that run infection prevention and control activities within a facility. So there are opportunities for partnership, and for us, we have learned that just having guidelines is not enough. So we have gone a step ahead and adopted the continuous quality improvement approach for implementing infection prevention and control. So we are working together with county departments of health, hospitals, and we're also pulling in development partners, because we realize everybody is required on board, building capacity, and you introduce, even if it's just one quality improvement concept at a time. If it's making sure that waste is disposed of appropriately, or making sure that we are all able to improve our level of hand hygiene to a certain capacity, or we are able to improve our supplies of basic things like disinfectants and sanitizers. So you pick on some components after carrying out assessments, and you work on them gradually to bring them to the level they are supposed to be. So this is just an example of what we have done in some of the hospitals, where we started with a baseline of 3%. You can see in one hospital, hand hygiene. Actually, the national average for hand hygiene as of last year was 5%. Hand hygiene adherence. So you can see they're not very far off, but they've been able to work over improving their compliance. And it is not easy, because there are a lot of dynamics around implementation. Because for you to have a successful program, then you need every other part of the system to be functioning. These are some of the guidance documents we've developed for COVID, and you can go to the Ministry of Health website. We have a COVID webpage, and all the guidelines are there, and we are able to make reference. We have gaps, of course, in terms of coordination. That's why the system doesn't function as it should. Compliance to guidelines, especially for infection control. We don't have clear accountability frameworks, whether it's public or private. And one of our biggest gaps is the lack of prioritization. Like I said, a lot of managers or leaders will think about buying products that they can see, as opposed to investing in a process which is not visible in the beginning, but the results show later on. Of course, there's also the challenge of externalization of IPC. Everyone thought at the beginning that IPC is an issue, maybe for the nurses alone. So it becomes very hard to get the buy-in of the rest of the clinical team, and you need everyone. The physiotherapists, you need the occupational therapists, everyone needs to be on board to understand what it means to implement infection prevention and control. So as I wind up, I know it's a broad area of discussion. Maybe just to emphasize that actually IPC is a system issue and all the building blocks are important. Even if I procured all the PPEs and I had all the policies in place and I had all my engineering controls, and I don't have a sufficiently trained workforce, it will not make a difference. So we need to look at all these components and the place of leadership, the place of partnerships, the place of coordinating mechanisms at all levels, and of course, working with existing programs because it doesn't exist on its own. If you go into maternal health, there's infection prevention and control. If you go into non-communicable diseases, you'll find infection prevention and control. So we need to work across the board. And one of the things we say as we work in this area is that infection prevention and control is not for the faint-hearted, because it is all about changing behaviors and practices. And changing behavior and practice for adults is difficult. So it needs teamwork most of the time. And again, it's all about knowledge. It's about attitude. Washing your hands is about attitude. Proper use of your masks is about knowledge and attitude. Making sure that policies and protocols are followed is about knowledge and attitude, and that affects practice at the end of the day. And we appreciate the fact that changing our culture to one that values infection prevention and control is a process. It's been about 10 years since the IPC program was established at the national level, and it's been quite challenging. It needs commitment from all levels, from the person who's implementing the protocol in the healthcare setting to the person who's developing the policies at the national level. It needs a lot of commitment, needs a lot of patience to change culture. And of course, one of the key components that we have found working for us is that mentorship and data sharing are really key components to creating culture change, because we can see when people see data from their own facilities and they begin to realize they have gaps, and this triggers a change in attitude and in practice. So thank you very much. That's what I had to share with us today. And I am hoping that we will have more opportunities to begin to unpack the different components of infection control so that we can find out what needs to be done better. Thank you. Over to you, Dr. Opanga.
Thank you so much, Dr. Wesangula, for that very engaging presentation. There's quite a lot that people assume out there that is not going on. When we have pharmacists in some of these key positions, especially responding to COVID-19, is when we really appreciate what we can do, as well as how much work is going on out there. I want to go straight to some of the questions. I want to encourage again people to send in their questions through the Q&A tab that is at the bottom of the screen. Amos Wambugu asks, what do you say about the new method of testing COVID-19? I don't know, is there a new method for testing COVID-19? Maybe we'll start there. Dr. Wesangula?
The new method of testing COVID-19, I will not be able to really speak into it because I know we've been focusing on the PCR testing. I don't know whether he's making reference to rapid tests. If it's a rapid test, the discussions are still ongoing, whether that is a direction that we are going to take as a ministry to also support maybe the quick turnaround time for results. If that is the direction that will be taken, then that means you can get your results faster. How does that reduce COVID-19? The faster or the sooner you get your results, then you're able to know whether or not you're going into isolation. Because if your turnaround time for results, for example, is 7 days, and if unfortunately you are positive and over the 7 days you've continued with your normal interactions, then that means you've been able to further spread the infection within the population that you're working with. So I think that's what I can be able to answer.
Okay. Clarice Ambales says, we have challenges accessing N95 masks and we tend to reuse the few we have. Is there a provision for disinfecting the N95 masks before reusing them? Or even cleaning them, I think a more appropriate word.
Yeah, we understand there have been challenges in terms of access, and it's not just here. The place of reusing single-use PPEs is a big debate, because once a product has been marked as single-use, the effectiveness can only be assured for that particular period. So if you disinfect that N95 mask, do you have the capacity to test its level of effectiveness? That's a challenge you have right now. And because we don't have a clear protocol on disinfecting and a clear mechanism of testing the effectiveness, then it's not one of those things that we have recommended at a national level. We still don't have a guideline for that until you are clear that even after disinfecting, the level of protection of the N95 mask or whatever PPE that has been used will still be able to be adequate for the healthcare worker. But I know with the challenges that we have, a lot of us are reusing the N95 masks. But again, I talked about occupational health and safety. When it comes to risk assessment and you're documenting exposures at the workplace, and you're getting to a point probably that a health worker has been exposed, you're beginning to work towards processes like compensation or cover. And when you begin to go into the detail and there's a breach in any of these areas, then it also affects the process going forward. So no, we don't have a provision for disinfecting N95 masks before using them now.
Okay, thank you for that. I think there's clearly, as you're saying, there's a challenge there with, reusing some of these PPEs. And as much as there is not much information out there, I think people out of desperation or out of what you called, just psychological sort of, issues that push people, they will tend to clean them or disinfect them based on what they think. And there's no way of really confirming whether that process was effective or, as you said, whether it's going to change the N95 mask itself. I have a question myself. You talked about certain risk factors for healthcare workers' infection. And I was just wondering there, is poor communication one of the risk factors? It wasn't there on the list of risk factors that you put there. And when I say poor communication, I am looking at a situation where different cadres of persons, now I want to call them healthcare workers, there would be people either involved directly with patients or processes, or people even cleaning as support staff. Should there be different forms of communication for different cadres? That's the question.
Yes, Doc, thanks for that question. And I would want to agree that yes, I would say maybe poor dissemination of information within different setups is a clear challenge. We are currently running another round of IPC assessment countrywide, and we are looking at coordination and communication structures. The communication structures are not as strong because the level of step down of information, for example, if I'm talking about, let's say, cleaning surfaces, and I want to address the support staff, and I'm talking about cleaning and disinfection, and I'm addressing a clinical team, the language I will use will be totally different. So I agree that messages need to be tailored to different audiences, and whoever is responsible for the infection prevention and control aspects in any setup should be responsible for breaking down information for different target groups for purposes of understanding, and also just simplifying the whole information so that everyone is able to do the right place. So I agree with you, that is a possible like point of that can contribute to the transmission of infections even in healthcare settings.
Yes, thank you for that response. I think maybe just for me, it's also, it also goes down to other institutions, not just health institutions, even educational institutions or any other, we're talking about reopening schools or reopening other forms of places where there'll be large numbers of people coming in. And some of these places also have been asked to put measures, including setups where suspected persons or confirmed persons with COVID-19 would be put. And you'll find that in these places, communication becomes so important. Would you advocate for tailoring of messages from MOH, because the ministry is quite particular about what sort of information is being disseminated? Would you advocate for tailoring of these information so that the language actually changes from the language that MOH uses, so that it can communicate clearly to the people in that setting?
Yes, it's possible to have that done from the level of the MOH. And we actually have two levels. Under the COVID task force, we have different streams of work. We have a stream of work that's focused on risk communication and health promotion. Then you have other streams of work on case management, infection control, and capacity building. So that's a possibility, and it can be taken up as well. And I think even for us that are in the infection control team, we can also consider it. It's possible, yes, to begin that from up there. And then we just disseminate, and people can customize and use them at the different levels of work.
Okay. Mwangi Mugo asks, is there any data on cases among providers in private retail pharmacies?
No, not yet. And I think this is a good area that we can even look at as a society. I think it's important for us to begin to look at that. And at the beginning, when I started, I said some of these areas have not been considered, because most of the time we talk about hospitals, we talk about healthcare facilities. And when you say healthcare facilities, I think if you're not keen, you will leave out the private retail pharmacies. And yet, this is normally the first point. For anyone who has a flu or who is unwell, this is likely to be the first point. So I think if we have an opportunity of beginning this process at private retail pharmacies, it would be good. And we are open to collaborate and see what's happening, because it's information that actually helps us to drive better action. So we haven't conducted any analysis.
Lincoln Mwasi is asking, where can he access the COVID-19 healthcare worker risk assessment tool? Hello?
Yes, Dr. Sorry, I lost you.
Yeah. So Lincoln Mwasi is asking, where can he access the COVID-19 healthcare worker risk assessment tool?
Okay, the healthcare worker risk assessment tool is part of the IPC considerations for COVID-19 guidelines. This is available on the website. And if you look at it, the last component that talks about occupational health and safety has the health worker risk assessment tool.
Okay, so that's accessible on the Ministry of Health website. Evans Rono is concerned about, I think, counterfeit masks. So how can you identify a real N95 from a fake one? I don't know whether you have any proposals
tough
there?
question. That's a tough question.
Yes.
But I know as of last week, there's an assessment that's ongoing. Just the way we do post-market surveillance for drugs or for medicines, we have one that's been happening for surgical masks and N95 masks. And I hope by the end of next week, we'd have a way forward so that we also are able to know how to be able to identify a fake and one that is actually genuine. So that's been a big challenge even for us. We are just beginning to look into that issue. So I don't have a clear answer for you today, but I hope once the report is out, we'll be better guided through KEBS as well. Yes.
Yeah, there's quite a lot of anxiety among people, even including those that are supplying products, because I think that when the market becomes porous, then all manners of thinking they can come in. And again, there's issues of capacity in terms of making sure that some of these products are, are captured. John Mugumura says it's a very good presentation. COVID-19 aside, there's the issue of friends, relatives whose health status is unknown, visiting patients in the wards in big numbers. Any comment on that?
Yeah, thanks, Doc. I think also the guidelines are clear on visitors, and that's why we talked about administrative controls in the hierarchy of infection prevention and control. So policies have to be very clear at a hospital level and enforceable as well, so that you limit the number of visitors to only necessary visitors, and also spacing them in terms of how many can be allowed in at any particular time. So many hospitals have actually been able to enforce the visitors policy, and you can see even when you go to hospitals, some of the visits have actually drastically reduced. So it's all about the facility, the management, and the policies that they put in place. But the guidelines are clear that visitors actually, or visits should actually be discouraged from taking place unless it's really necessary. It's unfortunate because then people are left anxious, but you see we are in uncertain times. And I think when you explain to the visitors, they should be able to understand why you have changed policies.
Okay. Anne Karanja is inquiring about the effectiveness of cloth masks. Now I think the government is well, it hasn't really stopped anyone from wearing cloth masks, but how effective are they?
Cloth masks, in terms of effectiveness, I think one thing we need to understand that you have different types of masks. And when it comes to effectiveness, cloth and the percentage of either bacteria or virus or any other microorganisms that can pass through the cloth mask, I think that is, when you look at that, you look at it from that level, then you realize the use of cloth masks might not be useful if it's in preventing the transmission of the virus. But the cloth masks are useful because they reduce the overall amount of droplets in any environment. So that is why the whole policy of public masking and even using cloth masks was actually allowed. If we could afford a surgical mask for everyone, then that would have been better, because then the level of effectiveness of surgical masks compared to cloth masks is different. Surgical masks are better. They have higher filtration rates compared to the cloth masks. But because of affordability and availability, and that's why the cloth masks are actually allowed and recommended for use in public spaces, so that you can reduce the amount of droplets in circulation in any environment.
Mm-hmm. Yeah, I think that's a very good answer, because again, it's all about risk reduction. And as you said, droplets, we've been informed again that the virus is aerosolized, so if cloth masks can actually just prevent and reduce that risk, that contributes to the overall, the overall measures that are put there to reduce transmission. Muia Mwalimu says, thank you, Dr. Evelyn, for the good presentation. Kindly comment on the quality of full PPE kit in use. How porous should they be? Protocols on putting on full PPE kit. Should one always have the surgical gown beneath the kit? This is quite technical, but you can attempt, or if you have the answers. So the quality of full PPE kit in use, how porous should they be? Protocols on putting on the full PPE kit. Should one always have the surgical gown beneath the kit?
Okay, so thank you for that question. And like you're saying, it's quite technical. First, on the quality, that also goes along with the aspect of quality of masks under investigation. The full PPE kit ideally should be non-porous. It should be water resistant. And when you're putting on your PPE, it's actually assumed that you have your scrubs on. So it's not about the surgical gown, but you have scrubs on. Then you wear the coveralls. But I also want to point out that at this particular point, we are actually reviewing the use of the coveralls, or what we've been calling the full PPE. We want to rationalize the use of PPEs, and I also realize at the beginning of the response to this pandemic, there was a lot of unknowns. There were a lot of unknowns on the pathogen. There were a lot of unknowns still on the modes of transmission. And I think we kicked off the response as a response that would have given maybe for the Ebola response. But now, as we have continued to gather more information, we are actually going to review the use of the full coveralls in the isolation centers, because once we've understood that this pathogen is a respiratory pathogen and you've assessed the risk, then the use of the full PPE as has been before might actually change over the next 2 weeks. So in terms of, so I think I've answered the place of the surgical gown beneath the full PPE. If you have scrubs, then you have your coveralls on, and what follows after the coverall is your apron, which normally is disposable. That usually is on the outer part of the full PPEs. So it's quite expensive to continuously provide this, and we all know these have been in short supply. So we are now reviewing the rational, the guidelines on the rational use of PPEs. But in the meantime, you can also still access the current ones. These are also available on the MOH website.
Good.
But
now,
in terms
yes.
of porosity, you assess. If you're going to handle a patient that has fluids and you're expecting that there's going to be contact and there's going to be splashes, then that is how you assess whether or not you would need one. But porosity, yes, whatever is used should be water resistant.
Yes, it's true. There's quite a lot of there's quite a lot of information that keeps coming almost every week regarding transmission and how this virus behaves. And I think it's just a matter of keeping up or keeping abreast with all the updates that are there. Because I would point out those. I think when the COVID-19 was first reported and we went into lockdown, at some point they also talked about transmission through the eyes. I think I saw it in one of the documents. And I don't know whether that has been updated. Would you have any comment on that? Because there are a lot of concerns. There are quite a lot of concerns. In fact, there's a question that talks about people just using money and exchanging money using, whether it's paper notes or whatever it is, and transmission. Because you'd imagine that somebody would have to, if there are virus particles or there are any infectious agents on these notes or objects, there would have to be a route of transmission. So maybe you could just comment on that and as we move forward.
Yeah, we actually haven't changed the policy on paperless transactions. I think it's just that the general public has kind of gone back to normal, forgetting that there are many possible routes of transmission still. And I'll just give this example. The contact, transmission can also happen via contact. And that's why the initial directive was for us to try and embrace paperless transactions as much as possible. Because if I'm not using a mask and I'm sneezing, definitely most people will sneeze into their hands and they will still touch the money and they will still pass over this money to another person who probably hasn't practiced any hand hygiene, and they will end up touching their nose or their eyes, and that would be it. So there hasn't been a change in that directive. The recommendation is still to advocate for the use of paperless transactions as much as possible. That hasn't changed.
Okay. Dr. George Mugi, apparently the culture of non-compliance has taken deep roots in Kenya, manifested in the way people walk around with masks not properly put on, in health facilities as explained in the presentation, on our roads, etc. Well, so he's just asking, where did the rain begin to beat us? Maybe he just wants a comment.
Yeah, that's Dr. Mugi. I think that's a valid concern. And one of the things I mentioned on the summary slide on culture change is not easy. It needs a lot of advocacy and continuous community engagement. And I think one of the things we have learned is that when people don't understand why they are doing something, they will do it for a very short time. But when there is clear understanding on the benefit of doing something right continuously, then the possibility of adherence is actually higher. And I'll just give a simple example. When we were even starting the ART treatment and HIV patients had to take medicines and had several pills to take a day. And we began to advocate for adherence other than compliance, making them part of the process. I think we recorded better results. So for me, I think this is the same approach. When people become part of the solution-making progress, then there's better adherence to the public health measures that have been put in place. But I feel sometimes there's either a general lack of understanding why I'm wearing masks. It's really not about the fine that is likely to be slapped on me, but it's the why. Why should I do it? For whose benefit? Am I benefiting? So I think that's where the rain probably started beating us, when it's about what will happen to me if I don't have a mask, other than how am I benefiting by wearing the mask? That's my thinking on that question.
Yeah, I totally agree with you. I think we have a culture of being guided by penalties rather than benefits of PPE. So, you know, like right now, there are people talking about the 20,000 Kenya shilling fine that is now tagged to not wearing masks, rather than talking about continuing to prevent the spread of COVID-19. And I think it all goes down to communication that I was talking about earlier. Should communication regarding COVID-19 evolve with the time, evolve with fatigue? Because there's an obvious fatigue towards COVID-19 now. In fact, when was it? I think on Monday, I was listening to something on radio, and it was a medical doctor that was actually being interviewed. And he said that the general population is getting tired of following the updates, you know, the daily updates by MOH. What, in your opinion, should change so that, you know, we keep up with whatever else is happening among the general population?
Yeah, Mike, I know a lot of people are tired of the same thing. I think when it gets to that level, then people stop listening and they go back to their daily routine. I totally agree with the sentiments that actually the communication strategy needs to change so that people begin to see a different angle as the pandemic evolves. Otherwise, it's become about the numbers and not really about what does that mean for me and what can I do to bring these numbers down. So I agree that actually the whole conversation around communication needs to be re-engineered so that it adds value at different points of the pandemic. Because what we did at the beginning of the pandemic is clearly not working for us now. Things are now different.
Yeah.
So I agree that that needs to change.
Tracy Muraya says, so far, majority of patients succumbing to COVID-related deaths or COVID-related illness are those with diabetes, hypertension. Have we been able to assess the impact of HIV positive patients as well as TB, especially with the current supply chain disruptions?
Not that I'm aware of. Tracy, thanks, Doc, for that question. Of course, a lot of the analysis that has been done, like we all know, have been around COVID-related deaths for those with diabetes or hypertension. But we still don't have information on the impact of HIV positive patients and those that have TB with the current disruptions in the supply chain. So that's a no, Tracy. And that's why I think as we work around this pandemic, there's so much that needs to be done. And I think just calling on all of us in our different spaces, we can all begin to find ways of conducting an assessment. And this can be done actually in collaboration with the different work streams, even within the Ministry of Health. So if you have work that's supporting the HIV or the TB program, suggestions can be shared along those sides, and the teams on that end can carry out assessments. And I think that's one way that we can be able to help each other actually be able to assess impact on different levels of service delivery as a whole. Because I know as you sit in different teams, focus is actually in one area. And unless you have multiple people working in different areas and bringing all this information together, it becomes very hard to put all these things together and make a meaningful understanding of what's happening throughout the healthcare system.
Yeah. So Daniel Jiguna says one of the risk factors for transmission of infection for healthcare workers, according to the presentation, is pre-existing medical conditions. Has the Ministry of Health taken a step to encourage healthcare workers to provide information on medical conditions they may be suffering from to protect them from infection? I think this is a very important question because it also touches on, you know, how far can confidentiality and a lot of private, how far do we get into our own privacy as healthcare workers, and how will that impact on delivery once the employer knows something about you that could contribute towards the whole COVID-19 situation?
Yeah, that's it's a very good question. Whether or not the ministry has taken a step to encourage healthcare workers to provide information on their underlying medical conditions, and at the same time be able to protect their privacy and assure them that it's not just about being vulnerable, but also your job is protected. For a long time, we have not had a robust occupational health and safety program. This actually should be part of an ongoing occupational health and safety program at all levels of employment, not just for the Ministry of Health, but of course the Ministry of Health provides guidance. So as of now, as we implement the risk assessment tool, that's the beginning, but we are also in the process of coming up with a care and safety plan for health workers, which we hope will go beyond this COVID pandemic, because there are many other exposures that healthcare workers have at work, like hepatitis B. How many of us report hepatitis B exposures while providing care during our routine work? So this is something that is being worked on together with the human resources for health and our human resources management department, so that now we are clear, and it will be part of the regular medical reports that will be filed by all healthcare workers which will be updated on a regular basis so that we're able to optimize our services, one, and also give healthcare workers the kind of care that is required. I've also realized that many times when we interact as colleagues, we always think about our patients. The last thing we think about is ourselves. So even when we implement programs and you have the provision for occupational health and safety, we have an infection control assessment tool. And one of the modules is occupational health and safety. Most facilities never even score a 40% because they don't even have a policy to talk about their healthcare workers and how they can be taken care of. Even basic vaccination in our healthcare settings is actually missing out. So this is something that is a work in progress. Of course, a big trigger from the pandemic, but we hope it will address issues beyond COVID, so that we are protected not just from infections, but other occupational hazards as well.
Yeah, I think that this discussion has quite a lot of depth and quite a lot of areas that really need a lot more time, to delve in. But it's good that we have you as an expert and somebody who is on the ground really dealing with these issues firsthand, and also even just at a managerial level. Dr. Elizabeth Ogaja says, what kind of support are you getting? Asking, what kind of support are you getting from the county health leadership in implementing the IPC program in the county health facilities? One of the challenges we experienced in the past implementing the policies and guidelines at the local level is that there were no approved SOPs to help in implementing the policies and guidelines at the local level. We were thinking of this in the context that SOPs are used in the pharmaceutical industry to ensure GMP compliance.
Okay, thanks, Doc, for that great question. It's rare that people ask you, what kind of support are you getting? It's always, what are you doing? So, Doc, thanks for that consideration. And because you've been at the county.
Hello?
That you can actually many days without making much progress. But I must say right now, in the wake of this pandemic, every county now has an IPC, like an IPC committee. The functionality is a different thing, but the fact that the counties have responded and they're beginning to put in place their infection prevention and control teams, for me, that's a big step. Over the last 10 years, we've never recorded 47 IPC county coordinators, but this year we now have contacts of all the coordinators for infection control. So that means even if it's a coordinator, there's a team that's being formed or it's already there. Number two, I think that's part of commitment from leadership. Apart from that, I think there's a place of budgets. We are seeing some counties beginning to commit specific budget lines to infection prevention and control. So that means then there's the infection prevention and control interventions have a life of their own. They can plan and you can begin to see things moving within the facilities. And like you have rightly put it, like one of the challenges you experienced was implementing policies and guidelines without approved SOPs. So what we have done now as we review the national policy and the strategic plan, we are also doing generic SOPs that can be adapted by different facilities or different settings so that it's easy to implement the interventions. So we are borrowing a lot also from what has worked in the pharmaceutical industry, and I always make reference to a lot of work that has been done in the pharmaceutical industry just to support systems to begin to run in a structured manner and in a standardized way. Of course, without SOPs, you cannot standardize any practice. And we also realize that the guidelines sometimes are too bulky and we don't have time to read through several chapters, but if we can develop SOPs from key processes or procedures and make this readily available, then it's something that is going to be useful to support the implementation at the local level. So it is work in progress as the guideline or strategic plan comes to a conclusion alongside the training modules which we have. there are also going to be a set of SOPs. And even for the COVID response now, we have sets of SOPs that will be made available, hopefully, by the end of the month. We are reviewing the IPC guidelines again, and we have learned a lot as we worked with them over the last like 3 or 4 months, and we realize the SOPs are a critical piece if implementation is going to be successful. Thanks.
Thank you. I know that, Dr. you're passionate about IPC as well as antimicrobial resistance. So I'm going to throw in a question here regarding antibiotics. Azithromycin is a drug that is at the center of COVID-19 treatment. Out there, we're also getting quite a lot of information regarding the purpose of its use. Some of the information that is getting out there is that it is being used for prophylaxis or prevention of pneumonia. What would be your comment towards the use of erythromycin for prevention, as well as communicating these out, given that most people would then just go out there and start looking for this antibiotic?
Yeah, thanks, Doc, for that question. Of course, there's a lot of information on the use of azithromycin, and I'm sure all of us have also seen the messages that are making the rounds on what you need to keep in the house as part of your treatment, pack for COVID-19, and azithromycin has been on almost each of those. So from an AMR perspective, of course, this is worrying. Number one, because in terms of prophylaxis, what is going to happen over the next couple of months is that you're going to create such selective pressure because of the overuse of azithromycin in the population. So if we had hoped that this was going to be one of those antibiotics that we were going to kind of lean on or count on for effective treatment, then we are going to actually have very slim chances. I'm sure if we began to conduct some AMR work around sensitivity and resistance to azithromycin over the next 6 or 12 months, we are going to see a difference because of the level of use and the level of exposure in the general population that would have happened when people would have accessed azithromycin, not for treatment purposes, but for prophylaxis. So the first challenge would be that, the selection pressure. So you have a population of bacteria that will be resistant to azithromycin. And when we will need this particular drug after the pandemic is over, it will not serve us. So that's the first part. So the overuse and the misuse is clearly out there. Yeah. Number two, in terms of messaging, I think we also have a big role to play in terms of educating the public on what to use and what not to use. And like we said earlier, a lot of the actions that we have taken have been also driven by panic. Nobody wants to get to the state where it's going to be said that they have a severe disease. Everyone wants to either remain in the asymptomatic phase or they want to have mild disease. So I think there's a place of education on rational use. And this is a space that the pharmaceutical profession can play very well, because a lot of these azithromycin doses are being bought either from our pharmacies or are being dispensed from our healthcare facilities. So we have a big role to play in terms of educating the public. But I also get the challenge. Recently, we launched the antimicrobial stewardship guidelines. So I think it's one of those things that needs to go out as we disseminate this information further. But we understand the power of the platform of professional associations, because we are able to speak to each other and we're able to provide evidence that can help support better practices at the end of the day. Thank you.
Yeah, thank you so much for that. I think that is a challenge to everybody in the pharmacy sector, the pharmacy workforce. It's important for us to play our role, whether you are in a private pharmacy or in a hospital or a clinic attending to patients, because with the word azithromycin going out there, whether it's through the media or whatever, you also have a lot of pressure from patients or persons taking patients to hospital to, to push prescribers to give azithromycin because they've heard about it. They hear it's so effective against COVID-19. And COVID-19 would be probably considered something that is so scary now, meaning anything lesser than COVID-19 would be effectively dealt with by azithromycin from a lay perspective. So as we go out there, let us be aware. And if you're working in a hospital or maybe a clinical pharmacist, it's important, just as Dr. Evelyn has said, let's get engaged in even just finding out, are there resistant patterns now evolving from the use of azithromycin in this pandemic? And that will add on to the whole knowledge as well as, handling or management of COVID-19. Just one last question, Frederick Githinji, because of time, kindly comment on the issue of disposal of masks as part of IPC. Yeah, this issue is quickly getting out of hand, and in his opinion, it is part of the source of transmission.
Thanks. Thank you, Mike, for that question. I know waste disposal or waste management, healthcare waste management has been one of our biggest challenges. And like I started by saying earlier, fixing a pandemic or fixing a crisis when you already had a weak system is not easy. So we had guidelines that went out on the disposal of masks and other waste that is generated in the public. First of all, I think for the healthcare facilities, waste disposal guidelines are pretty clear. For the public, that is where the challenge has been, because surgical masks or these single-use masks, ideally, because you don't know who is carrying an infection, each of these disposal mechanisms need to be very clear, one, and the disposal needs to be well done. So the recommendations that have been provided for in the guidelines that the single-use masks should be disposed of in a bin that is lined and covered. But now it comes to the practical issues in our society. How many households can afford a lined bin? That's one question. And what happens to the bins that are lined after they are full and they need now to be subjected to the next level of disposal? So now this brings in the place of collaboration, even at the community level. And I made mention to community engagement and leveraging on the systems that are ongoing. So over the last 1 month or so, we've been building capacity for community health volunteers, because that's now the linkage between the community and the health facilities. And part of what the community health volunteers or the community health assistants are supposed to help address is the question on waste disposal. Because if you have masks that are being disposed in the general public, then these need to find themselves into a health facility that has a proper waste disposal mechanism. So the place of linking communities to the community health volunteers who are also linked to a health facility or a public health officer within the either the sub-county area or the county area is a critical point to support appropriate disposal of waste. But I know even as I say this, you're beginning to ask how many of the public health officers have you seen, or do you even know them? But if the community engagement will work, and there are clear linkages between the communities that are using masks and the CHVs and the facilities that have the capacity to adequately dispose of the waste, then that would be good. But in the absence of these systems, then that leaves a population that is exposed to another potential source of infection. So I agree there are gaps there. And as we work around the process, I think just to emphasize the place of the community health volunteers that are in communities and the linkage to facilities for appropriate disposal. And some of the guideline requirements can be implemented. others cannot be implemented. But I think the most important piece also would be to communicate effectively on how these masks should be disposed. Because even in our own houses, I'm sure you're also struggling with the disposal of masks. If you have a car, probably the masks for the last 1 week are still in your car. If you have, when you get to the house, you're wondering, should I put this into the general waste or should I put this into a specific waste bin? So those are real issues that we are struggling with. We still haven't gotten the perfect system to address the waste disposal, not just of these masks, but even gloves that are being used in different setups within the community now that the economy has reopened. So we have critical areas that are still not fully addressed, but it is still work in progress. Thank you.
Yeah, thank you so much, Dr. Evelyn Wesangula, for taking time off your busy schedule to come and talk to us about infection prevention control in the era of COVID-19. This has been a very stimulating debate. In fact, I think there's so many areas now, most participants would agree, are areas that we need to go and check and also improve on, just to, one, prevent transmission among healthcare workers, as well as ourselves and other people that are around us. I want to also appreciate all the participants who took time off again this morning to be with us during this webinar. This is an ongoing exercise by the Pharmaceutical Society of Kenya, and we've created our own task force, COVID-19 Response Task Force, PSK, which we really appreciate your support. I also want to appreciate the other cadres that came in for the webinar, the pharmaceutical technologies or other cadres that are here. I also want to say thank you to my co-moderator, Dr. Sylvia Opanga, and the CEO of PSK, Dr. Daniela Munene, for making these happen. Time is gone, and we want to apologize to Dr. Wesangula for keeping you longer, I think, because it was really a very good discussion you brought for us this week. I want to pass on the mic to Dr. Daniela to close this webinar. Thank you.
Thank you very much, Dr. Mungoma and Dr. Opanga, for wonderful moderation. And of course, to our distinguished speaker, Dr. Evelyn Wesangula. I have never seen so many questions on these COVID webinars. We've had about 50 questions. And so the level of engagement was very high. Thank you, participants. So from me and the PSK team, it's have a good day, and let's meet next Wednesday for another COVID-19 dialogue. Bye-bye.
Thank you. Bye.